pleasure to introduce Professor Oliver. He will talk to us about highlights in the management of metastatic prostate cancer.
Great, and thank you very much. A pleasure for me to be here today. You know, I just had about 25 minutes to cover a broad topic. And what I decided to do was to cover some recent advances. It may not take all the 25 minutes, and I think if we have a little bit of time for questions, that'd be great. What we really have, and this is something that is, I think, critical to understand, is a real evolution in the way that prostate cancer is being treated from a global perspective. You know, we have the disease states, which I think many of you might be familiar with. We very broadly sort of divide people into those with metastatic disease and non-metastatic disease. We can divide people categorically into those that are castrate sensitive and those that are castrate resistant. And this sort of paradigm that I've displayed here are the way we begin to think about this disease overall. And if we look at this, it turns out that there are advances that I think are relatively important in the recent years on both non-metastatic castrate-sensitive disease, the metastatic castrate-sensitive disease, and the metastatic castrate-resistant. So I'm going to cover some old paradigm-changing trials that I think are reasonable to be highlighted. First of all, the STAMPEDE high risk M0 castrate sensitive, where data was presented at ESMO. Secondly, the PEACE-1 trial in the metastatic castrate sensitive with data from ESMO. The PROFOUND data, where we've had two, I think, important New England Journal manuscripts in essentially the last year, a little bit more than the last year, but FDA approvals that I think are practice changing. And then more recently, the VISION trial, which was presented at ASCO and then published in New England Journal in print just a couple of weeks ago. First of all, I'm going to start out with a presentation that Gerda Tard gave representing the STAMPEDE investigators. And I think many of you are familiar with STAMPEDE if you follow the prostate cancer field. They've been amazingly impactful. And really, we owe a great deal as a global community to the advances that have been made in the UK. By the way, a little bit in Switzerland as well, but Silke Gilliston you can see is there, but it's predominantly UK investigators. This is a long title, but basically, it's the STAMPEDE platform in the high-risk, non-metastatic patient. Now, here's how it was designed, and it's a little bit unusual. There were a whole series of patients who were being treated with androgen deprivation and radiation therapy as the standard of care for those with non-metastatic castrate-sensitive disease. As it turned out, there were two sequential trials evaluating whether or not the addition of another hormone to standard of care might improve the outcomes. And you could see that it was standard of care plus AAP, that's abiraterone plus prednisone, or standard of care abiraterone prednisone plus enzalutamide. And it turns out that there really did not turn out to be much differences when you added enzalutamide to abiraterone. So they've ended up merging these two data sets. So we're going to be looking at the abiraterone plus standard of care or the abiraterone enzalutamide plus standard of care all in one analysis because the abiraterone enzalutamide did not add. Now, this was the primary endpoint, metastasis-free survival. And if you look at the number of events, you could see there were only 180 events in the combination arm. And for the ADT monotherapy arm, it was 306. Hazard ratio was 0.53, very, very, very strong p-value. 6-year metastasis-free survival improved from 69% to 82%. Obviously, a clinically relevant finding. Overall survival was also impacted in a clearly positive way. Here again, you see the hazard ratio in the upper right, 0.6, and a p-value that is very strong. The number of events in the upper right-hand corner, 147 versus 236. Really no question that this improves overall survival and actually takes this group of patients up to 86%. And these were individuals who had negative bone scans, negative CAT scans, but typically had Gleason 8, 9, 10, and may have had T3, T4 disease, may have had nodal positivity. There were also some patients in the category that had a recurrent disease after radical prostatectomy, but that is a minority of the patients. The majority of these patients were de novo, non-metastatic, high risk, as measured by Gleason score, PSA, or clinical stage, but non-metastatic by conventional imaging. By the way, no PSMA PET was used. In the next trial, which I think is important, and this is a little bit controversial, we have the piece one. This was presented at ESMO by Karim Fizazi. And in the design, there was again a collapsing of arms because it was found to be differences that were not apparent, thereby allowing a consolidation of patients. So there was actually a 4-arm design, and these individuals were all metastatic castrate sensitive. All were getting the standard of care, which was defined as ADT docetaxel. The experimental aspects were to add either abiraterone or to add radiotherapy to the primary, or to add abiraterone and radiotherapy to the primary. Analyses were done which indicated that the radiotherapy did not really make a difference. So what we're going to be looking at is the standard of care, which in this case is ADT docetaxel plus or minus abiraterone. The co-primary endpoint was rPFS, and you can see very impressive rPFS data here, 4.5 years versus 2.0 for standard of care. And these individuals clearly had benefit from the addition of abiraterone. The overall survival in the intent to treat population was also favorable for the standard of care plus abiraterone. Remember, this is ADT plus docetaxel. And what we're seeing here is a hazard ratio of 0.75. This is obviously, to me, an important new finding, but there's more to the story. And then I'm going to come back and give a caveat. When the patients were stratified by so-called high volume criteria, and this is charted high volume, so 4 or more metastases, at least one of which was outside of the axial skeleton or a visceral met. So they had 5 lesions, or they had 1 lesion that was in, say, a humerus or a femur outside the axial skeleton, but they had a qualification for high volume patients. That was the patients that are being analyzed here. And here you can see that the hazard ratio is 0.72, showing that ADT docetaxel with the addition of abiraterone shows an improvement in overall survival. This is the low volume patient. So these are individuals that did not have 4 or more bone lesions and had no lesions outside of the axial skeleton. And what you see here is no difference. The hazard ratio is 0.83, but the p-value is 0.66. Yes, you may argue that it's underpowered, but if you look at the number of events, 131 and 123, this is really not the number of patients treated. That was not the number of events. The number of patients treated, relatively small, but the number of events was only 29 and 31. We cannot really make a distinction here in my mind. If we look at the de novo high volume patients, you can look at the charted regimens, the original Stampede regimens. Then you move on to the updated data, and then you look at the latitude data. What you can see is there's a progressive improvement. But what we've got in piece one is something that looks a little bit better again. And that is really what brings us to the controversy. Let me go back for a second. This indicates that the addition of abiraterone to ADT docetaxel adds value, but we do not have any data that shows that docetaxel will add value to ADT abiraterone. In other words, if the control group were ADT abiraterone and the experimental group was docetaxel, we simply have no data. And I'll say that, to me, that's an important issue. I think that the abiraterone is likely to add a bit more value as compared to the docetaxel, in part because you affect both low and high volume patients in a positive way. But do you add value with a triplet instead of a doublet? And I still think there is room for discussion. I've spoken to good people in the field. Some people say yes, some people say no. I'll leave it for your evaluation. Now, I'd like to move into some of the castrate-resistant discussions. And if we look at this particular chart, it's all the life-prolonging trials for those with castrate-resistant disease. And you can see a series of trials that I call frontline, and this is just ADT before the use of the agents, docetaxel, Cipacel-T, abiraterone, and enzalutamide. The post-docetaxel trials like Tropic, Cougar 301, Affirm, ASUICOC trial with radium, where it was before and after. The profound data I'm going to discuss. The card data is important data, but I'm not going to discuss it here today because that's been published for quite some time. And the card data is important because it's a post-ABI enza and post-docetaxel setting. And in the card trial, there was a clear improvement with cabazitaxel as compared to a second-line hormonal agent. But I'm also going to be talking about the VISION trial, which is brand new. For biomarkers today, we have homologous recombination repair genes such as BRCA2, BRCA1. In the USA, we have two PARP inhibitors, olaparib and rucaparib. However, rucaparib is only a provisional approval and not a full approval. For mismatch repair genes, we also have an approval in the United States. This is not a typical global approval for the anti-PD-1 pembrolizumab. So mutations in homologous recombination repair genes or mismatch repair genes have targeted approved therapies. I'm going to first of all look at the DNA repair defects. And it turns out, I think we all know this, there's a lot of heterogeneity in prostate cancer. And the olaparib study that looked at the initial phase 3, published back in April of last year, the profound design is displayed here. These are individuals who progressed after novel hormonal therapy, either ABI or enza. They could also have progressed after a taxane, and then that was a stratification. And they were looked at in terms of cohort A and cohort B, with the randomization to olaparib or physician's choice, which is typically either abiraterone or enzalutamide. And there were several endpoints. Actually, radiographic progression-free survival was the primary, and then various things like overall survival were secondaries. If you look at the homologous recombination repairs, you can alterations study there in the bottom, BRCA1, BRCA2, ATM, etc., as you can see on the slide. Here's the data from over 4,000 patients tested. First of all, 31% of the patients tested had quality control issues, but 28% had DNA repair defects, with BRCA2 being the most common at 8.7% of those tested. Here's the primary endpoint, and you can see progression-free survival in cohort A, which is BRCA1, BRCA2, and ATM. Hazard ratio 0.34, obviously a strong finding. There was a second New England Journal paper in September of last year, almost exactly a year ago. And here, the intent to treat analysis demonstrated improvement in overall survival despite crossover. 66% of the patients crossed over, but the hazard ratio in the intent to treat analysis in cohort A was 0.69. There was no overall survival benefit in cohort B. If you looked at the adjusted analysis for cohort A, and this takes into account a sort of contrived, not real survival because it deletes the crossover. This is not an intent to treat, but nevertheless, you can see that if you look at those who did and did not cross over and take into account the crossover, that you end up with a very strong hazard ratio of 0.42 for overall survival, and that's in cohort A. There's now been an FDA approval for circulating tumor DNA, and I think this is important because a lot of times prostate cancer patients are hard to assess, and that difficult assessment and with regards to getting tissue is something that is global. PSMA targeted therapies. PSMA is expressed on the surface of prostate cancer cells. We have the new PSMA lutetium data just presented online on June 23rd, in print in September. I happen to be the first author. And in the VISION trial, we looked at patients who have been previously treated with either abiraterone or enzalutamide or both, have been previously treated with at least one taxane, typically docetaxel, but could be treated with two. They had to have a PSMA PET positive lesion, and then they were randomized to the standard of care, which was primarily hormonal therapy, radiation, bisphosphonates, etc., or standard of care plus the PSMA lutetium. Two overall endpoints were seen, rPFS and OS. Both were positive. The hazard ratio for overall survival was 0.62 for the favoring the PSMA lutetium. On the rPFS, it's 0.4, favoring the PSMA lutetium, unequivocal findings. In terms of PSA decline, also unequivocal improvement, 46% versus 7.1%. And at the bottom, you see the objective response rate, which was actually over 50% of those with measurable disease in the PSMA lutetium arm versus only about 3.1% for standard of care. In summary, ADT and abiraterone and the high-risk M0 de novo subset, I believe is impactful. I will adopt that as part of our standard of care for those who meet appropriate criteria. Is the PEACE 1 data enough to change the standard of care for those with high-volume metastatic disease? Some say yes, some say no. I believe that abiraterone adds to ADT plus docetaxel, but I'm unsure that docetaxel adds to ADT abiraterone because of the lack of that control group. I think profound data changes practice for those with homologous recombination repair gene mutations and those who have progressed after abiraterone or enzalutamide, and they may have progressed after a taxane as well. And I think the VISION trial will change the standard of care in the third-line setting for those individuals who progressed after abi or enza and at least one or two taxanes. And with that, I'll wrap up and simply say thank you very much. I enjoyed the opportunity to be here today and hopefully have a little time for questions if you so desire.
Dr. Oliver, thank you very much. I know it's noon time for you. It's clinic time for you, I know. It's evening here in Cairo. Thank you very much for your nice, elaborated lecture. I just want to ask here about, I see that now there is no, for the castrate-sensitive prostate cancer, metastatic prostate cancer, I don't see new agents, but I see new regimens. And I think that there was the standard of care was androgen deprivation therapy, ADT first, and then we are adding plus to that is the abiraterone acetate, and then we are adding plus the docetaxel, and maybe also for the low volume radiotherapy. Do you think if we add 3 agents like that, triple agent rather than 1 agent, and then we fail after the triple agent, what would be the window for treatment after that? Because we are blocking, we are giving chemo with abiraterone acetate, with androgen deprivation therapies. So what do you think that if we fail after that?
Yeah, so a couple of good things. First of all, let me mention that there are some novel agents now being looked at in the castrate-sensitive space. The PSMA lutetium is being looked at in a trial called the PSMA Addition trial, and that PSMA Addition trial has the potential to change standard of care yet again. It's a large global trial that'll be looking at the PSMA lutetium in a phase 3 setting. One of the real issues is, if we use all of our good agents up front, what do we do when these agents fail? And I'll simply say we don't really know the answer to that yet. I think ideally we'll change modalities. We'll end up in a position where we'll introduce an agent that's not been seen before. We know cabazitaxel is different than docetaxel. Cabazitaxel might be a regimen to look at, but we have progress. But of course, we need more. Men don't like to be castrated. That's obvious. Who wants to have a testosterone of 0? My way of thinking is that we have much more work to do. And perhaps one day we'll be able to treat men in truly novel ways and to treat them in a way without castrating. That would be a dream come true.
Okay, thank you. But do you think that the quality of life with this triple therapy would be better than only androgen deprivation therapy for the castrate-sensitive prostate cancer?
No, I think that the chemotherapy does add a deficit. We've seen that from prior analysis in Stampede. But for those who are seeking longevity, perhaps the younger patients are willing to tolerate some of the issues. I think the chemotherapy could be an appropriate choice for those with high volume metastatic disease. I would not use triplet therapy for those with low volume metastatic disease.
Thank you.
Can you hear me?
Yes, I can.
Yes. Hello, Dr. Sutters. It's a pleasure having you again. My question is about the PEACE trial. Can you tell us whether the 4 groups included were they homogeneous in terms of the primary treatment they received? Did they have prior primary treatment to their prostates, whether surgery or radiotherapy, or were they all primary presenting metastatic disease?
This was a de novo trial, as best I understood. This was not for the recurrent patients. So these were a fairly homogeneous group of individuals who presented with metastatic castrate-sensitive disease. And then in the 4-arm design, one of the randomizations was to the radiation to the prostate. And of course, half got that. But in their analysis, according to Dr. Fazazzi, that there is not a addition of benefit from the radiation. That's why he collapsed the arms.
Thank you.
Dr. Oliver.
Does that answer your question?
In terms of the results, I understand that, but I wonder was that fair to conclude this conclusion by this relatively small numbers of patients?
I can say that Dr. Fazazzi believed that the data were robust enough in the high volume subset and in the overall analysis subset. I have some trepidation over the low volume subset simply because the number of patients is small and the number of events are small. I think we've seen from prior Stampede data that in the low volume subsets that the addition of radiation may make a benefit. And I'll simply say in the low volume patient, we do treat the primaries here, typically with radiation. There are also ongoing trials to determine if radical prostatectomy in the low volume metastatic subset will have benefit. The truth is we don't have an answer with regards to the radical prostatectomy.
One question. Thank you for a nice lecture. I want to ask about if androgen deprivation therapy is enough for Gleason score metastatic with a low glycemic score, or we should add ablatamide from the start for low volume and the glycemic score less than 8.
I had a little trouble hearing, but I think the question was about bicalutamide and the low volume subset. Is that correct?
Okay, it was low volume, glycemic score less than 8. We start with metastatic prostatic cancer. We start with androgen deprivation therapy only, or complete androgen blockade with ablatamide or something like that, with enzalutamide, or just androgen deprivation therapy alone, and then we follow up the patient.
You know, I think that is a little bit of a controversial point. The data in the low volume subset from the Stampede study indicated clearly a benefit of the addition of abiraterone. One issue with abiraterone, of course, is the cost. It's expensive. But I don't know if you've seen the data where you can give one abiraterone with food, or perhaps two with food. There's a study from University of Chicago in the metastatic castrate-resistant setting showing that one abiraterone with food is actually quite good and maybe the same as 4 without food. There's a study from Canada that shows that 2 with food may be the same as 4 without food. That's not a direct answer to your question. We typically will add in the abiraterone unless the patient is older or particularly low volume. We still do, on occasion, an intermittent approach, and we don't use abiraterone in everybody, but we try to consider the abiraterone in everybody given the strength of the data and particularly the Stampede data in the low volume subset.
Okay, for oligometastatic prostatic cancer, we start from the start. We can do this regimen that you told us about it. That was androgen deprivation and ablatamide and enzalutamide plus enzalutamide for oligometastatic. Oligometastatic prostatic cancer, sensitive, hormonal sensitive.
Yeah. Okay, for the oligometastatic, I think it really depends on how you define the oligometastatic disease, and that's scan dependent. If you're talking about oligometastatic by molecular scanning, like PSMA PET, I believe it's a whole different beast as compared to those who are being defined as oligometastatic by conventional imaging. So I have a tendency to think about the oligometastatic by reference to the scans that are used, with PSMA being one subset, conventional being another. Now, back to your question. For those who have oligometastatic disease by molecular imaging, I am using a targeted radiation toward the metastases, plus treating the primary tumor, and I'm only using a more limited duration of androgen deprivation. So there, instead of using androgen deprivation forever, I may only use androgen deprivation for 1 year. But I don't really know what the proper duration is, and I'll simply think that there is going to be a lot of discussion on this point going forward because we don't have good data.
Thank you very much.
I do see a question online about the PSMA therapy before or after cabazitaxel. And, you know, what I'll simply say is it may depend on the geography, it may depend on the insurance, it may depend on the payments. I think many individuals will have the PSMA therapy beforehand, but remember that there are more trials on the way. The Vision trial is the first trial, but there's also going to be a pre-chemotherapy trial with metastatic CRPC using the PSMA lutetium. I think 5 years from now, it's likely that we will be using PSMA before we use chemotherapy in metastatic castrate-resistant disease. But that's a future point, not now. We have to get the approvals first. I mean, I believe the Vision is an approvable trial based on the design and the clear positivity, but the regulators have yet to speak, and we need to hear from the regulators. We also need to understand the cost. We don't understand the cost yet.
Thank you very much for your lecture.
Dr. Oliver, in metastatic castrate-resistant prostate cancer, after exhaustion of many lines of treatment like hormonal treatment, second generation, and Taxotere, is there any role for mitoxantrone? Because if you don't use this, you are going to use maybe another more expensive medications which may be not available or the patient cannot afford. So is this any role for mitoxantrone maybe after abiraterone and Taxotere?
You know, it's a good question, and I don't truly know the answer because we don't have a lot of trial data from there. I will say that I do use mitoxantrone at times in that setting, and at times the response is better than what you might think. So mitoxantrone remains an active agent, and I do utilize it in some patients, even though more expensive agents have better trials.
I have a question.
Okay, yeah. One question for me, for Dr. Oliver, please. Do you think that we are in the era that we are going to treat arbitrary state like ADT, like androgen deprivation therapy, which I mean that when we fail with androgen deprivation therapy in castrate-sensitive prostate cancer, and the patient is CRPC, we still put him on androgen deprivation therapy. Do you think that the time will come for arbitrary acetate that when we fail with arbitrary acetate, we are going to continue with arbitrary acetate like ADT, and then we add like a docetaxel or something like that, we add a chemotherapy? This is one question. The second one, for high-risk prostate cancer, are you still using the standard imaging techniques, or you're using now the molecular imaging? Because many of us now are using molecular imaging and they are bypassing the standard imaging of CT and bone scan.
Yes, I'm glad you raised that. We're using molecular imaging preferentially, although we're still having some reimbursement problems here in the US. So, you know, it's a bit of a hybrid. I'll simply say if I could do one test, it would be the PSMA PET. I mean, it's a better test. And by the way, when we get a PSMA PET, we use a PSMA PET CT, so we really get, it's not a high-grade CT, but we get the fusion CT when we get the PSMA. With regard to your first question, a really good question. I'm unsure of the answer, but those studies have yet to be done. I will simply conjecture and say I don't know, but on the other hand, it's a very good question to ask.
I think one of the audience had a question for you, Dr. Oliver.
Hello, can you hear me?
Yes, I can hear.
Regarding the Peace 1 trial with the use of docetaxel plus ABI in the high risk, in the high volume population, so how you see the results with the use of ABI plus ADT or apalutamide plus ADT with now apalutamide median overall survival is not reached, and ABI plus ADT we have almost 51 to 52 months. There is no great difference between ABI plus docetaxel or ABI alone. Plus, what's your comment also about this combination of ABI and ANZA that has proved failure in multiple settings in the metastatic castration, that both agents don't get the benefit of adding both together rather than any of them alone?
Yeah, so I think, you know, we now have multiple trials to indicate that adding two of the novel hormones together adds little value. We have that from the abiraterone apalutamide. We also have that in abiraterone enzalutamide. So I'm not really enthusiastic about putting the two together. Your point on the docetaxel and is very well taken. You know, I tried to raise this issue. We don't really have all the control groups we like. By the way, to be fair here, I didn't discuss the ADT apalutamide. I did not discuss the ADT enzalutamide. I only talked about the new data with the ADT abiraterone, and that was presented in two contexts, both the M0 and the M1, and for the Peace 1 and for the Stampede study. But I think there's still room for skepticism about triplets. And I raised this with Kareem. Dr. Vizazi is believing this high volume subset is deserving of triplet therapy. I simply say that until we have the appropriate control group, that it's a little bit conjectural from my angle. Chemotherapy does add toxicity. Abiraterone adds expense. I mentioned how to cut down on the abiraterone expense, perhaps by reducing the dose and taking it with food, but that is unproven in large studies. Nevertheless, these are great topics of discussion. In the end, we cannot treat a patient unless what we offer the patient is affordable to the patient. We cannot prescribe therapies that are unaffordable. That's, we all know.
Any further questions? Thank you very much, Dr. Oliver, for your presentation and for asking our questions and sharing us in the discussion. Thank you very much.
Thank you for the opportunity to be here. Hope you have a wonderful conference. Thank you again.
Hello, everybody. I would like to thank you, the committee, for this kind invitation to talk about metastatic renal cell carcinoma to this congress. So I am Dr. Colomba. I am medical oncologist in the genitourinary group in Gustavo Rossi Institute. So I will try to make a presentation about recent data in metastatic renal cell carcinoma. So this is my disclosure. And the landscape of systemic treatment in metastatic renal cell carcinoma did change strongly in a few decades. Just to say the context, very long time ago, we have only a first generation of immunotherapy with interleukin-2 and interferon, and we had at this time very low response rate in metastatic renal cell carcinoma patients. And in 2006, it was the antigenics area that really changed the paradigm of the treatment in metastatic renal cell carcinoma, with response rate around 30% in patients. Around, I don't know, maybe 10 years after, it was a revolution, because for the first time we have two new treatments with nivolumab, that was an immunotherapy, and cabozantinib, that was a new generation of anti-angiogenics that finally, for the first time, was associated to a benefit in terms of overall survival in second line in metastatic renal cell carcinoma pre-treated by anti-angiogenics. And then 1 year after, for the first time, the first line in metastatic renal cell carcinoma changed, standard of care changed, and nivolumab plus ipilimumab, a combination of immunotherapy, was associated to a benefit in terms of response rate, overall survival, and median progression-free survival compared to sunitinib in a subgroup of patients according to IMDC score. And in intermediate and poor prognosis patients, combination of immunotherapy was for the first time associated to a benefit compared to sunitinib. Then we have several phase 3 trial in first line in metastatic renal cell carcinoma that made association of anti-angiogenic and immunotherapy, and all these phase 3 trial finally changed the standard of care, and sunitinib was not anymore the cornerstone of the treatment in metastatic renal cell carcinoma. So several trial, phase 3 trial positive in first line, and a lot of combination options change the standard of care very recently. But just talk a little about adjuvant setting. We have some trial that compare from the standard of care was placebo, some treatment in adjuvant setting, but at this time, this trial compare and address the question of add an anti-angiogenic after nephrectomy in this patient. And finally, only one trial, extract trial, was positive in terms of disease-free survival, but finally, the ratio between benefits and risk was not really positive. And finally, any trial changed standard of care in adjuvant setting. But recently, in ESMO 2021, we had the result of the Keynote 564 trial that addressed the question of immunotherapy in adjuvant setting by pembrolizumab for 1 year in patients that underwent a nephrectomy for a local disease that was clear cell renal cell carcinoma, and for patient that was oligometastatic patient that was totally underwent surgery and did not receive systemic therapy. This patient was randomized between pembrolizumab for 1 year and the other one was treated by placebo. And finally, when we look at the patient, we have some patient, oligometastatic patient with not evaluable disease. It was finally a low part of the patient, so that did enroll in this trial. And it was aggressive disease, stage 3 and 4, or all the patients with node in the surgery nephrectomy, and some patients with stage 2 with an ISUP histoprognostic grade 4 with sarcomatoid component was enrolled as well, and some oligometastatic patients that had nodes after nephrectomy in less of 1 year. And the endpoint was disease-free survival, and after short follow-up, we can see that there is a benefit for the groups that did receive immunotherapy with a disease-free survival positive with an hazard ratio around 0.7. We have a trend toward median overall survival very early, but the data were not mature at this time. And finally, the safety were clear, okay, with very few grade 3 to 5 events according to immunotherapy. So this trial with pembrolizumab was positive and probably will change the standard of care, even if the data concerning the overall survival is not really mature at this time. Other trials are still ongoing, testing immunotherapy or combo in adjuvant setting, and we will have some data in that kind of aggressive localized tumor, and we will see if finally maybe immunotherapy can change the paradigm of treatment in adjuvant setting. So indeed, as I said, Keynote 564 probably will change the standard of care. Safety was okay, and we had early a significant delay in the onset of the disease. Let's come back to metastatic renal cell carcinoma. So the same combo in several types of tumor was stated in a few decades. Anti-angiogenic and immunotherapy was associated and evaluated in several trials with renal cell carcinoma, and a lot of trials recently met the endpoint, the main endpoint. So we will talk about these 4 very interesting trials: the CheckMate 214 with nivolumab and ipilimumab. Then we talk about the Keynote 926 with axitinib and pembrolizumab. Recently, CheckMate 9ER was positive, associating nivolumab and cabozantinib. And finally, CLEAR trial was clearly positive recently as well, and addressed the question about the combo with lenvatinib and pembrolizumab in first line in clear cell renal carcinoma. So just to resume, I will talk about rapidly the result of the CheckMate 215 with nivolumab and ipilimumab. So it was the first trial that did change the standard of care compared to sunitinib in patients with intermediate and poor prognostic score according to IMDC score, with a clear benefit in terms of PFS and overall survival very early, with a hazard ratio around 0.6 at this time, and 0.8 in terms of progression-free survival. Finally, another trial with pembrolizumab and axitinib confirms the benefit of combo in first line compared to sunitinib, with at this time a benefit in terms of overall survival with a combination of pembrolizumab and axitinib, anti-angiogenic, with a median follow-up of 1 year. The hazard ratio was around 1.5. And we recently have, after a follow-up of around 42 months, we have an update of the Keynote 4 to 6 trial. And finally, there still are a strong benefit in terms of overall survival, with an hazard ratio around 0.7 for the combo axitinib plus pembrolizumab. But in terms of median PFS, we had a median PFS with the combo around 15 months. Very strong benefit compared to sunitinib that was associated to a median PFS around 11 months in this patient. Response rate was superior as well, around 60%. And finally, with this follow-up, we have a complete response rate around 10%. That's what I said. And that was really interesting, was finally low primary refractory disease with the combo around 11%. In terms of efficacy, when we look of the patient, the subgroup according to IMDC score, finally we can see that the benefits was clearly strong for the patient with intermediate and poor risk patients. That was a poor subgroup with an hazard ratio around 0.6. And we can see that in poor prognosis patients, the benefit in terms of overall survival was not really significant, but in terms of PFS, we have a little trend towards the combination as well. About the response rate and the complete response rate, we have finally a response rate around 10% with the combo. And we have finally another positive trial, a phase 3 trial that was testing cabozantinib associated to nivolumab in first line compared to sunitinib. We have to notice that the cabozantinib dose was around 40 milligrams compared to 60 milligrams. That was the dose in monotherapy, notably in relapse. So after a median follow-up of 18 months, we have a positive trial in terms of progression-free survival according to a blind investigating committee for the RECIST criteria, and a hazard ratio around 0.5, very strongly positive, with a p-value very, very low, around 0.0001, and the median PFS around 70 months. In terms of overall survival, after a median follow-up of 18 months, we had a benefit very, very early with an hazard ratio around 0.6. finally, all the subgroup of patients did benefit of the combination by nivo-cabo. And in terms of objective response rates, it was really interesting with an objective response rate around 60%. And that was clearly interesting as well. It was very, very low primary refractory disease with a very low of progressive disease around 5.6%. Complete response was around 8%. In terms of median PFS, we have, accordingly to the investigated blinding committee, an hazard ratio very low, inferior to 0.5. And a median PFS around 19 months. And we had recently, I think, in the beginning of the year, we have the result of CLEAR trial, a trial that investigates a combination with lenvatinib and pembrolizumab. Lenvatinib is as well a new generation TKI that that was approved in thyroid carcinoma already. And this trial addressed the question of the combo in first line compared to another combination that was we found in some country in relapse that was associated lenvatinib and everolimus compared to sunitinib. It is as well a positive, very positive trial with, in terms of median progression-free survival, an hazard ratio according to the combo lenvatinib plus pembrolizumab compared to sunitinib, around 0.4. So in terms of median overall survival as well, it is an early positive trial with a benefit in terms of overall survival around 0.6%. The benefit was clear in all group of patients concerning the age of PD-L1 expression or IMDC risk score. All the patients benefit from the combo. In terms of response rate, it was clearly impressive with a response rate around 70% in the patients, 71% in objective response rate compared to 36 with sunitinib. And again, a very, very low rate of patients with primary refractory disease, around 5% of patients with progressive disease. And a complete response rate, very impressive at this time, around 16% as well. So when we look at the group, the benefits with the combo was superior to the standard of care at this time, that was sunitinib first line. With finally, when we look at the median PFS, we had a median PFS around 24 months. It was for the first time we have a median PFS in first line metastatic renal cell carcinoma around 2 years. These are the same, a benefit in terms of median overall survival, as I said before, and a response rate as well. So we have several phase 3 trials in first-line metastatic renal cell carcinoma that demonstrate a clear benefit of the combo, IO or IO anti-angiogenic. So the guideline in first line did change very recently. So just for the memory, before the recent data, we have to split the subgroup of patients according to the IMDC score. So good risk patients, the standard of care was clearly not anymore sunitinib, but pembrolizumab and axitinib for all the patients that can receive the combo. And for intermediate and poor risk patients, we have two options before, pembrolizumab and axitinib, and nivolumab plus ipilimumab. In 2021, a new standard of care was added with the association of nivolumab plus cabozantinib in all the patients, dependent of IMDC score. And recently we have, again, the combo with lenvatinib plus pembrolizumab. So when we look the NCCN guideline version, again, all the combo was included for metastatic patient with finally favorable risk according to the score IMDC. We have three options that associated immunotherapy plus one anti-angiogenic. And for poor intermediate risk patient, you have at this time 5 options. That was the combo, 3 combo, axitinib plus pembrolizumab, lenvatinib plus pembrolizumab, or cabozantinib plus nivolumab. And you have the combo with IO, ipilimumab plus nivolumab. And cabozantinib is an option in first line according to the result of CABOSUN, a phase 2 trial. For non-clear cell, I just will say a few words after. So now, how to choose the best combo for our patient? We have a very good review that demonstrates the benefits of associating finally an anti-angiogenic to an immunotherapy because of the impact of the microenvironment tumoral, and finally the immunomodulating impact of anti-angiogenic that finally potentializes the effect of immunotherapy. So which is the best combo finally, IO or IO2 anti-angiogenic? That is a question of finally what is the best goal for the clinician. This is finally the complete response. Do we want to have all the patients with complete response? Maybe we can see the rates of progressive disease, very low progressive disease as best response in the trial. Maybe we want very few patients with a primary refractory disease to the combo, or maybe we want to have the best objective response rate, so we will choose a combo that is associated to the best objective response rate. Or maybe we want to have a very rapid tumoral response for the patient that are maybe symptomatic with pains or dyspnea or something like that. Maybe we want to see a very low of patient with toxicity, because we know that combo can be really toxic and it's a challenge for the physician to deal with it. Or maybe we want to have the best quality of life, and finally the response rates is not our main objective from the physician. Or maybe we would just want to have a benefit in all comer. Sometimes we have to look the IMDC score, because some combo are not associated to a benefit in some patients. So we have to determine the IMDC score. Or maybe sometimes we don't have to do it because the combo is a good option in all comer. So all this question is some different point for the clinician that has to be addressed. But let's compare the trial. We can do it. usually, but we try to do it again to determine finally which is the best combination. When we have the first 3 positive trials with axitinib and sunitinib, and finally axitinib with avelumab, we have a difference in terms of hazard ratio, in terms of overall survival, with an hazard ratio very low for some combo when we look a follow-up that was clearly the same. But now we have several trials, so maybe we can look other points that can be really interesting. So when we look after more follow-up, a longest follow-up, according to the Checkmate 214, we can see after 42 months, finally, the benefit in terms of overall survival is totally confirmed with in a control treatment in the patient treated by immunotherapy, finally a median overall survival still not reached. Compared to the trial with axitinib pembrolizumab, the median in terms of overall survival is finally clear, with a difference around 10 months in terms of overall survival. That is really interesting. When we look the Checkmate 9R, the follow-up is shorter. So, but we can see that we have an hazard ratio in terms of median overall survival that are clearly near of the other one, and that is clearly the same for the combo of lenvatinib pembrolizumab. So maybe combo are really the same in terms of efficacy when we look at median overall survival. Now, if we look about objective response rate and complete response rates, clearly we had complete response rates around 10% with nivolumab and ipilimumab in this patient after a follow-up of 42 months. And it is finally the same with axitinib pembrolizumab. When we have more follow-up, finally we have complete response rate around 10%. And we will have a look, and we need more follow-up in this patient, because after around 30 months, we have a complete response rate, very impressive, around 16% with the combo of lenvatinib pembrolizumab. So that is really interesting, and we will confirm this higher complete response rates in this patient. And in terms of PFS, clearly a longest median PFS with the combo lenvatinib pembrolizumab around 2 years, compared to the other combo around finally less than 20 months, 15 months with axitinib pembrolizumab, and 70 months with cabozantinib nivolumab. When we look the other trial, and the other trials are associated other immunotherapy and anti-angiogenic, it's clearly a median PFS, very impressive as well, when we add cabozantinib and atezolizumab around 20 months. And finally, with tivozanib and nivolumab as well, according to the data of phase 2 trial. And we find again a very low rates of progressive disease patient. So how to choose the first line? We have to discuss all together, and for some physicians, the benefits in PFS for all comer is more simple, and some physicians will finally prescribe for all the patients an immunotherapy and a VEGFR inhibitor for all the patients. Sometimes we can see the objective response rate that is more important with the combo of IO and TKI compared to IO-IO. For the combo of IO-IO, finally, complete response is not more frequent because when we have enough follow-up, we can see that the complete response rate is the same with axitinib pembrolizumab. And finally, it's like lenvatinib plus pembrolizumab is associated to a higher complete response rate. So it's no more a point to choose the combo. But it's like the combo of IO-IO maybe is more toxic. Indeed, 80% of the patients did receive the 4 boost of ipilimumab is a treatment 214. And finally, for the patient, it is really well tolerated to receive only the monotherapy monthly in the hospital. And finally, the patient did not receive the toxicity of the TKI. That is clearly impact quality of life. What's more, some physicians will say, okay, maybe the IO-IO combo is the more option, it's the best option in first line because after a progression to IO TKI, what is my best option? Reintroducing a TKI can be less efficient after a combo of IO TKI, maybe compared to introducing a TKI after the combo of IO-IO. And let's talk about very rapidly about biomarker. Clearly, sarcomatoid component tumor did benefit a lot of the immunotherapy in our trial. And clearly in the trial with nivolumab plus ipilimumab, the benefits of the combo IO-IO was particularly impressive in patients with a sarcomatoid component that was associated to a PD-L1 expression superior. Let's talk about a safety now, few words. That is clearly a new challenge for the physician. Before, renal carcinoma physician used to deal with the anti-angiogenic toxicity. It was frequent, it was well known, it was manageable, and finally, rapidly reversible. Clearly, this toxicity was dose dependent, so you just stop the anti-angiogenic, and most of the time the patient rescue of the toxicity and came back to a grade 1 or 0, and it was clearly manageable in routine. These side effects around very frequent like diarrhea or hand and foot syndrome was well known and clearly impact the quality of life, but the physician used to deal with it, and the patient finally with some drug holidays and finally dose decrease, it was clearly feasible to deal with the toxicity of anti-angiogenic. Now we have to deal with the toxicity of the combo that associated the toxicity of the anti-angiogenic and the toxicity of the immunotherapy. Clearly, it's like maybe the immunotherapy did potentialize the toxicity of the anti-angiogenic, and when we see the grade 3/4 side effect, it is side effect well known with anti-angiogenic, maybe a little more frequent. Sometimes that kind of toxicity was not reversible, and particularly the toxicity immunomediated to immunotherapy. So it is more rare and maybe it's not so easy to manage, and the physician need to receive a training for this toxicity and maybe to make part of a specialist network to discuss of this toxicity, the finally treatment of this sometimes immunomediated toxicity, and finally discuss about stop the treatment or resume the treatment after advice and after to have refer the patient to a specialist, maybe an internist or endocrinologist or neurologist or something like that. So the physician can't deal with this toxicity alone. He needs to connect to a specialist immunotoxicity network, and sometimes it is time consuming because you have to present the case of the patient and discuss and refer the patient to a specialist. So it's not totally the same thing that before. New generation of anti-angiogenics that has cabozantinib or maybe lenvatinib are clearly the multi-targeted agents that see a lot of potential targeted driver. And these multi-targeted agents are more efficient because they can target a new driver in carcinogenesis in metastatic renal cell carcinoma. And the drug, as cabozantinib, had clearly an impact in bone remodeling as well. So it is particularly a drug with interest in bone mets. So data did demonstrate that this drug can target the bone. And clearly, in bone tissue, it increased the number of osteoblasts and decreased the number of osteoclasts. And finally, participate to the stimulation of the bone matrix. So cabo do works in bone mets and can be a really good option in this patient that under anti-angiogenic have very bad prognosis. This is a powerful option. So new generation TKI is clearly efficient, but there is associated to maybe a little more toxicity that we have to deal with it. So the addition of VEGFR and immunotherapy seems manageable, but clearly a little higher in the trial. So it is well-known toxicity that we used to have with anti-angiogenic in monotherapy, but clearly was increased with immunotherapy. In terms of grade 3/4 side effects, the rates was clearly maybe the same, but as I said before, it is not the same side effects, and sometimes we need to refer the patient to a specialist. It's like with finally the combo IO-IO, the rates of grade 3/4 is clearly around less of 50%, maybe well tolerated when we compare the grade 3/4 rates with IO-TKI. But in the trial, we start to receive the data of quality of life. And for example, in the CLEAR trial with lenvatinib pembrolizumab, quality of life was not really decreased around the combo. And the safety was quite the same, a little higher when we had immunotherapy to lenvatinib. Let's talk a little about the drug that will be interesting in future. We had a lot of hope in new drugs that can target the metabolism in renal cell carcinoma, and particularly the glucose and glutamine metabolism. And we have a glutaminase inhibitor that was tested in phase 1 and phase 2 recently. In phase 1, we did have some encouraging data in clear cell renal carcinoma with, in few patients, significant partial response is patient with objective response rate around 50%. So then a phase 2 was designed after the phase 3 that investigate the association of glutaminase inhibitor and cabozantinib, notably in renal cell carcinoma and non-clear cell carcinoma. Cantata trial was presented recently and reported the data to the addition of glutaminase inhibitor to cabozantinib. And finally, the endpoint was the progression-free survival, and the trial was clearly negative with no benefit to the addition of a glutaminase inhibitor to cabo with a median PFS around 9 months. In all the subgroup, there are no benefits to the combo. A new drug was testing recently that was IF alpha inhibitor that targeted a driver in metastatic renal cell carcinoma and localized, but in clear cell carcinoma, IF is very often activated to an alteration of VHL gene in sporadic renal cell carcinoma and in hereditary VHL carcinoma. So different trial testing an IF1 alpha inhibitor that is called belzutifan, that is MK6482 in some trial and in a different setting. And a phase 3 trial is ongoing in metastatic renal cell carcinoma in 3rd and 4th line compared to the standard of care that is now everolimus. So the result of the trial is pending, but the FDA did approve this year IF1 alpha according to the result of a phase 2 in a patient with VHL associated renal cell carcinoma that had a diagnosis of renal cell carcinoma with a VHL germline alteration and with at least one solid renal localized tumor measurable. So according to the result of the phase 2, the belzutifan is now refound by FDA. In the future, I think maybe we had some benefit to the addition of new drug that maybe can modulate the microbiota. And we have in ASCO 21 the result of a phase 1 that finally demonstrate the benefit to the addition of a drug can stimulate the microbiota in metastatic renal cell carcinoma and clearly potentialize the response to immunotherapy. In the future, we will have the result of a new combination and suite therapy in first line in metastatic renal cell carcinoma, and we have the COSMIC trial 313 that address the question to the addition of cabozantinib to nivo plus ipilimumab in first line compared to the standard of care in intermediate and poor prognosis patient, that is nivo plus ipilimumab. Few words in non-clear cell now. We had the result in the last ASCO to the MET inhibitor savolitinib in papillary. We know that type 1 and type 2 papillary non-clear cell carcinoma is very often associated to MET alteration. So we have this trial that compare sunitinib versus savolitinib, a MET inhibitor, in papillary renal carcinoma, and the association of savolitinib plus immunotherapy in MET alterated advanced papillary renal carcinoma. And it is really interesting with a response rate around 60% in these patients that are a poor prognosis disease and a median overall survival more than 2 years. So very interesting data from this phase 2 presented by Dr. Suarez at ASCO. And clearly the benefit was particularly interesting in MET-driven patients. When we look the combination with savolitinib and immunotherapy, the benefit was clearly superior in patients with MET alteration. So it is first data in a driven trial in non-clear cell. We had recently the result of an association nivolumab plus cabozanimab in a phase 2 trial in non-clear cell. So this trial had 2 cohorts. First one cohort enrolled a lot of papillary renal carcinoma and some unclassified and translocation renal cell carcinoma, and the cohort 2 enrolled very few patients with chromophobe. And the objective response rate in the cohort 1 was around 50% with the association of cabo and nivolumab. And the median PFS around 1 year. In chromophobe, there are no clear response, but very few patients. In terms of efficacy, we have very few progressive disease in the cohort 1. And finally, a disease control rate, very interesting, was 97.5%. The safety was clearly okay with around grade 3/4 side effect around 30%. So my first conclusion in non-clear cell renal cell carcinoma, it's like data from immunotherapy. Immunotherapy is not clearly a good option in this patient. So now a trial is addressed the question of combo of nivolumab plus ipilimumab in frontline. So we will have the result of the SUNFORCAST trial that is still enrolling patients with non-clear cell renal carcinoma. So it's a non-randomized phase 2 trial testing nivolumab plus ipilimumab in first line in this patient. Another trial in non-clear cell renal carcinoma is testing now an association of immunotherapy and TKI with the combo lenvatinib plus pembrolizumab, and it's still enrolling patients. We will see as well the result of a MET-driven trial, SAMETA phase 2 trial, that testing savolitinib plus durvalumab compared to sunitinib. And we will see that finally the encouraging data from the phase 2 can be confirming in the phase 3 trial. And now, waiting for the result of this trial in non-clear cell renal carcinoma, standard of care in first line for papillary renal carcinoma is cabozantinib, according to the stroke trial that demonstrated a benefit compared to sunitinib. So it's cabozantinib, the new standard of care in papillary renal carcinoma. When we talk about a clear cell renal carcinoma, some take-home message as far as I am concerned. I said maybe do not start therapy too quickly. We have some patients that can be asymptomatic, that can be associated to a good prognosis disease. And finally, it is interesting to test the kinetic of the tumor burden. And if this patient with very low tumor burden, maybe with only lung mets infrasymptomatic, sometimes it's interesting to not start therapy too quickly and consider local treatment as surgery or radiotherapy in this patient. Patient with good prognosis, the standard of care is not sunitinib anymore. It's an anti-angiogenic plus immunotherapy. In intermediate and poor prognosis patients, we have several choice, and according to the refunding, according to the country, we can prescribe IO plus anti-angiogenic or IO with nivolumab and ipilimumab. The best combo is a question of objective for the physician and the patient. It is a complete response, the objective response rate of the safety and the quality of life. Clearly, in sarcomatous tumor patients, there is a clear benefit from immunotherapy, and combo IO can be really interesting with a high complete response rates. PD-L1 is a predictive biomarker, and it is associated to a high response rate with IO as well. And we need more reliable biomarker in this disease. In second line, don't change too quickly after a combo. It's like cabozantinib today as the best rationale after pembrolizumab plus axitinib or pembrolizumab plus avelumab, and we have a prospective trial that is demonstrates the interest of cabozantinib after combo with the Cabo Point trial that is still ongoing. All anti-angiogenic are possible after IO, but cabozantinib can be the most efficient option in patients with poor prognosis. In patients with intermediate of good prognosis, we can prefer a more selective anti-angiogenic if the patient is likely to receive several lines. In patients with brain and bone mets, cabozantinib is a good option, and CABOMETS is a trial that is enrolling patients with brain mets and is actually investigating the response of cabozantinib in brain mets. Now we have a lot of options. The strategy in metastatic renal cell carcinoma is more complex, but still questions are today addressed without clear response, clear answer. Are all immunotherapy equivalent or not? What is the best duration of immunotherapy? Can we stop after complete response? Can we stop after, I don't know, partial response? Can we stop after 1 year, 2 years? Which combo for which patient? As I said, all is a question of finally objective for the physician and the patient. Molecular classification in renal cell carcinoma, is it feasible in routine or not? What is the best strategy today? It is a combo or the second? That is a good question, because now patient will receive maybe pre-therapy tomorrow. And in the patient in which the immunotherapy is stopped. Finally, in which patients the re-challenge of immunotherapy can be efficient or not. Many thanks for your attention, and I have time for a few questions if you want.